The apnea-hypopnea index, as developed by Dr. Christian Guilleminault, is the gold standard in diagnosing sleep apnea. And despite the quantity of neurophysiological signals which were obtained during an overnight polysomnography, most of the data collected is ignored, and treatment decisions rely heavily on the apnea-hypopnea index. Over the next few minutes, I want to impart the limitations to the apnea-hypopnea index. The AHI should be at best considered a crude and imprecise metric of obstructive sleep apnea. The calculations of the AHI assume that both apneas and hypopneas are fundamentally equal in their biological effects. An apnea is a cessation to breathing during sleep for more than 10 seconds, caused by the complete collapse of the airway. A hypopnea, on the other hand, is a partial collapse of the airway sufficient to cause a desaturation of blood oxygen saturation by 3 to 4%. Both an apnea and a hypopnea last for 10 seconds. During a polysomnography, researchers will add up the number of events per hour. When both apneas and hypopneas are combined into one measurement, it is assumed that both the apneas and hypopneas are fundamentally equal in their biological effects. Evidence to date is limited on the relative contribution of apneas versus hypopneas. So the question to ask is, if an individual is completely stopping breathing during their sleep, can that be the same as an individual who has a partial restriction to their breathing during sleep? It's easily argued that because apneas occur as a consequence of the complete upper airway collapse, they may impose a greater impact, larger surges in sympathetic activity than hypopneas, which result from the partial collapse of the upper airway. With a hypopnea, the threshold for blood oxygen desaturation is arbitrary, and little evidence supports a cutoff point of 3 to 4%. With any threshold, it assumes that all hypopnea events that exceed the chosen threshold are equivalent. And in this example here, if you look at a hypopnea with a 4% blood oxygen desaturation, is that biologically equivalent to a hypopnea that has an 8 or 10% oxygen desaturation? Certainly greater degrees of hypoxemia are likely to have greater effect. But again, one hypopnea is not considering whether the desaturation is 4% or whether the desaturation is 10%, because it's still one hypopnea. Another factor to take into consideration is the clustering of events during sleep. Apneas and hypopneas, they can occur evenly across the night, or they can cluster during a particular segment of the sleep period. To give you an example, 2 patients who have a total of 160 events over 8 hours of sleep. Although the AHI index is exactly the same, approximately 20 events per hour, the first patient may have all of their events within the initial 2 hours of sleep, whereas the second patient, they have their events equally spread throughout the night. It could be easily argued that the second patient may be more prone to the clinical effects of obstructive sleep apnea because they're not getting any hours of good sleep. The AHI index, which tabulates the number of apneas and hypopneas, does not incorporate any information about the duration of these events. For example, a patient with a long respiratory event may experience substantial hypoxemia but have a relatively low AHI. In other words, you can have one patient that's stopping breathing for 1 minute. They can have a substantial reduction to their blood oxygen saturation, but that's still one event. Versus you may have another patient who has more frequent events and therefore a much higher AHI, but they could have minimal exposure to hypoxemia. In addition, non-apneic respiratory events that do not meet the scoring criteria for hypopnea are associated with heart rate changes and increased expiratory pharyngeal resistance. The AHI does not incorporate the increased work of breathing associated with the occurrence of disordered breathing events. Partial or complete collapse of the upper airway increases the work of breathing, which in turn results in acute cardiovascular effects that may be of clinical significance. And furthermore, The AHI correlates poorly with the key causes and consequences of the disease. It's time for sleep medicine to accept that the AHI is a parameter that crudely integrates the pathophysiology of obstructive sleep apnea. It is likely that several different parameters are needed to reflect disease complexity: average desaturation amount, event length, the frequency of events, and the AHI. It just doesn't have to be one measure. Here is an interesting paper. We already spoke about considering an apnea, and even if the individual is stopping breathing for 1 minute versus an individual who may have many apneas. Which is the more severe? In this paper here, which followed 5,712 participants over an 11-year follow-up, 1,290 deaths had occurred. After adjusting for demographic factors, the AHI index, smoking, and prevalent cardiovascular metabolic diseases, it was found that individuals with the shortest duration events had a significant hazard ratio for overall mortality. The relationship was observed in both men and women and was strongest in those with moderate sleep apnea. Short respiratory event duration, a marker for low arousal threshold, predicts mortality in men and women. Arousal threshold is the propensity to wake easy from sleep. If you have a low arousal threshold, you wake from sleep very easily, and doctors may prescribe sedatives to help ensure that these patients achieve a deep sleep. We also need to look at breathing in this instance. If low arousal threshold is a marker for overall mortality, let's start teaching these patients to sleep deeper. How can we achieve this? Number 1 is nasal breathing. If you breathe through an open mouth during sleep, if you wake up with a dry mouth in the morning, you're likely to feel unrefreshed, but also you will spend more time in light sleep. Light sleepers, it's easy to be brought out of sleep. A second factor is we need to be activating the parasympathetic response and dampening the sympathetic stress response. We do that by slow breathing. Slow breathing through the nose using the diaphragm helps individuals activate the parasympathetic response and to achieve deep, deep sleep. With a deeper sleep, the individual is less likely to be awoke from the slightest of stimuli, so we can improve the arousal threshold. I conclude that when we are looking at the AHI index, there are several factors that we need to consider. Number 1 is, are apneas and hypopneas equal? Number 2, is the duration of an apnea the same? In other words, if an individual stops breathing for a minute versus an individual stopping breathing for 15 seconds. Number 3, we have to consider desaturation. One individual may desaturate down to 90%, or another individual could desaturate down to the mid-80s, the mid-70s, or even lower. Number 4, we have to consider the phenotypes of sleep apnea. Low arousal threshold seems to be one of the key phenotypes as a marker of overall mortality. Bringing in breathing re-education will significantly help to improve a deeper sleep and possibly to reduce the overall cause of mortality in obstructive sleep apnea.